Class is now starting. All attendees are in listen-only mode.
Hello, my name is Dr. Erica Brandenstein. I am an OBGYN at Reed Hospital in Richmond, Indiana, and I'm very honored to be with you here today to talk to you. I'm going to be talking to you today about substance abuse in the obstetric patient. And as you know, this is a growing problem in our community in Indiana, in our communities in Indiana, as well as across the country. And so we all need to be open about discussing these issues. And I'm going to go through a lot of them today, mostly focusing on the pregnant patient and the effects on the fetus. So my objectives for you today are going to be how we identify these patients in the office so that we can help them, some of the associated maternal and fetal complications with various substances that used in pregnancy, how we best manage these patients, and I will also talk some about how we manage the infants and what we're doing to prevent substance abuse in pregnancy. So one of the most important things, and the thing I think you need to realize first when approaching pregnant patients who abuse substances, is you need to recognize it as a medical condition, as a behavior disorder that's chronic and relapsing. Relapse is part of the disease. And we need to recognize it. We need to recognize it as a disorder that is significantly affecting the patient's brain. If you can recognize it as a medical condition, then you'll be more likely to approach it, to be able to approach the patient with compassion. Try to avoid viewing it as a moral issue. It really is an illness. It's not a personal failure or a sign of weakness. And I can tell you, every pregnant patient that I've ever talked to who's been addicted to drugs during pregnancy never intended ever to be using during pregnancy. They never planned a pregnancy while they were active in addiction, and they never planned to bring a baby into the world withdrawing. It's a medical issue that they're struggling with, and as providers, it's our job to recognize that and to help them rather than to judge them. So I'm just going to give you a few statistics here. Obviously, opioid use in pregnancy has been increasing significantly, particularly between the 1998 and 2011. It doubled. Polysubstance use is very common, and oftentimes we do see people come back with tox screens positive for meth and cocaine in addition to heroin. And also the non-medical use of prescription drugs is increasing significantly, and they are commonly being sold on the streets. There was a national survey performed between 2012 and 2013 on drug use and health, and what they found was in patients ages 15 to 17%, 14% were using illicit drugs, and then in the next age group, 8.6%, and then in 26 to 44, 3.2%. So at least 8.6% of people in that age where people tend to have their first pregnancy were using illicit drugs. These are just some statistics from our hospital. And as you can see, the overall percentages of positive drug screens per month when taking into account all the deliveries as well as the positive tox screens were pretty high, ranging between 17% and 30% over the first few months last year. And that's been pretty significant. So obviously you can see by this chart that it's a big problem. So I'm going to talk to you a little bit about how we identify these patients in our office. If you can't identify them, you can't help them. And I think the most important thing that you can do to clearly try to identify these patients, connect with them, and help them is to perform a face-to-face interview. So we do have our patients at their initial visit. We do screen them with a verbal face-to-face interview, and I'm just going to go through some examples of what can be used. So there's something called the 4 Ps: parent, partner, past, and present. And these are basically just general questions that you can ask people to identify if they have a problem. One is asking them about their family. Did any of your parents have a problem? The other is, do they have a partner with a problem? Have they had difficulties in the past? And then specifically asking them if they've consumed any alcohol or drugs within the past month. And then obviously any yes answer should trigger further questions. The craft is basically most useful in adolescents and young adults, which oftentimes do become pregnant. where you can identify the problem and even get some hints at the severity of the problem. Just asking, do they use substances to help them relax? Have they ever used by themselves or alone? Do they forget things? Ask them about their family, and ask them about their history. Have they ever gotten into trouble with the law or in school due to substance abuse? And then in general, the standard is 2 or more positive answers indicate need for further assessment. But with a pregnant patient, I would say any positive answer would warrant further testing and further probing into that situation. So we do urine drug screens on our patients. Some institutions do universal drug screens where they do them on everyone, and some do them on patients selectively. And at our institution, we do use universal drug screening on all the patients, but there was a period of time where we did select patients. If you're going to be selective, then you need to choose patients that are most likely to be higher risk. So patients with late or no prenatal care need to be screened for substance abuse, because oftentimes people who are abusing substances try to avoid the healthcare system because of fear. If they have a diagnosis of a stillbirth or placental abruption, which is premature detachment of the placenta, then you want to screen these people, because these can be common effects of using substances in pregnancy. Patients should always have autonomy, even patients who abuse. So you should always perform your screening with the patient's knowledge and consent. There has been some controversy as to whether or not hospitals should screen everyone, or if hospitals should be selective, which in itself can be controversial. But however, there's no uniform statewide policy on that. It has to be approached at a hospital basis. You also have to recognize that there are reporting requirements. And when we have patients come in with and have a positive toxicology screen, and they have children in the home, we have to notify the Department of Child Services. And obviously, patients, when you're choosing your screening method, you have to consider that patients are developing a fear of criminalization and maybe avoiding the healthcare system because of the drug screening. What we do with our patients is we're very upfront with them, and we do try to maintain their autonomy by obtaining a consent. And our consent just has a general statement in it. I understand that for the safety of that of my infant, a blood and or urine sample will be obtained and can be used to test for. And we include like the prenatal labs in that, a regular blood count, and then also toxicology screening. So we just present it as a normal thing that we need to know in order to best take care of the mother and of the baby after birth. And whenever you do come up with a consent that you feel comfortable with, always have it reviewed by your hospital legal team. So as far as for the mothers, we mostly just use a urine drug screen, and we do that at our initial visit in the office. And we also, whenever a patient presents to the hospital for anything and comes up to labor and delivery, we do a urine drug screen. And doing it this way, we do catch most of the patients that do get prenatal care prior to the time of delivery. For the infant, there are various ways that you can test. One is a urine. So a urine bag is placed over the infant's genitals shortly after birth. You can also do meconium testing, and one of the newer things that actually gives you a longer period of the pregnancy to test on is collecting the cord segment, which we actually do on all our patients now. So first I'm going to talk about marijuana. That's the first substance I'm going to talk about because, as you know, a lot of states are legalizing marijuana and the use has become extremely popular, and we need to address this because a lot of people have the mentality that, it's legal in some places, it's just smoking, it's not going to hurt my baby, it's not going to hurt my pregnancy. If I use marijuana during pregnancy, I'm not a drug user in pregnancy. And I think that we need to recognize this as a potential problem. Marijuana is the most commonly used illicit drug in pregnancy, and the self-reported prevalence is 2 to 5%. So that's self-reported. So you can imagine it's maybe double or triple that. 48 to 60% of marijuana users prior to pregnancy will actually continue in pregnancy. And obviously this has gotten worse and worse, and actually this has worsened since it's been legalized. Marijuana does cross the placenta, and it's been found to be in the fetal plasma levels at levels up to 10%. And there's some limited data to show that it's also transmitted to the breast milk. So there is not a whole lot of consistent data on marijuana use in pregnancy on potential outcomes, but there are some brain development models in animals that show that may be associated with mental and behavioral health issues. There was no structural anatomic defects associated with it, but we should also recognize that marijuana is addictive in some people, and it is a gateway drug that can lead to other drugs which have been proven to cause harm to the fetus and birth defects. The studies that have been done on marijuana use in pregnancy are obviously limited by some co-founders. Like a lot of those patients abuse other substances. They have other issues like lifestyle issues. A lot of the studies are based on self-reporting, or recall bias comes into play, and the data is inconsistent. So I wouldn't say that there's a lot of great data on marijuana use in pregnancy, but I think there is enough data that we can counsel their patients that it does go to their baby and that it could potentially be harmful to their child. So it's always discouraged for pregnant patients and also in lactating women. With regard to medical marijuana, I have had some patients come in that moved from different states saying, well, this was prescribed by my physician, I'm taking this medically, it should be okay. But what we should recognize is that medical marijuana is not regulated or evaluated by the FDA. And there are no approved indications for marijuana use during pregnancy. Smoking in general should not be condoned during pregnancy, because it can be associated with low birth weight and even stillborns. And there are a lot of alternative therapies with pregnancy-specific data that you can use. Like if you have depression or anxiety, there are meds that have been studied in pregnancy. If you have a lot of nausea or vomiting, there are also meds that are safe in pregnancy. So really there's no excuse that a patient can use for continuing medical marijuana in pregnancy. Next, I'm going to talk to you about opioids, and heroin is kind of the new hot topic for use in pregnancy because heroin use is increasing so much. And I'm sure you're all hearing on the news about heroin overdoses in your community and how that's increased significantly over the past couple years. Heroin is the most widely abused opioid and does have the highest addiction potential. And heroin can actually alter the brain chemistry so acutely that patients can use it one time and become addicted. Not only do you have the issues associated with addiction that can affect the mother's health and the fetus's health, but there are also some kind of other medical issues that are associated with it, which include endocarditis and osteomyelitis, because when patients are using dirty needles, they can introduce bacteria into their bloodstream. These patients are also at increased risk for hepatitis B, C, and HIV, which can be transmitted to the fetus, and also which increase our risk to our healthcare workers. There are a lot of opportunities for exposure during delivery by vaginal route or by cesarean section. Typically, patients who are withdrawing from heroin present in about 4 to 6 hours complaining of symptoms. And oftentimes this involves obsessive thinking. And even patients who get clean can have drug cravings persist for years after stopping. The most common withdrawal symptoms are abdominal cramping, nausea, insomnia, anxiety, and irritability. And I can tell you my experience with patients presenting an active withdrawal from heroin, it's very hard to get a history and physical on them. A lot of times they're very irritable, they're sometimes combative, and until you make them feel better, until you actually give them treatment, it's almost impossible to get through a conversation with them. And so these patients present in extreme distress from withdrawal. I'm going to talk to you next about some of the effects of opioid use in the fetus, and this includes not just heroin, but this can also include use of prescription drugs, either prescribed or on the streets, that are opioid agonists or opiates, like Percocet or OxyContin. So opioid use in pregnancy can actually lead to fetal death with acute withdrawal. So the baby can acutely withdraw inside the womb, and it can lead to fetal loss or a miscarriage. There is possible risk of birth defects in certainly a risk of growth restriction. There's risk of placental abruption or premature detachment of the placenta. There's significant risk of preterm labor in these patients, and there's also risk of intrauterine passage of meconium, or of the baby having its first bowel movement in the womb. And this is not something that's completely uncommon. However, when babies do pass meconium in the womb, they can aspirate that at the time of birth, which can increase the risk of delivery. So basically, what infants experience after birth when their mothers are addicted to opioids or opiates, and we call NAS, or neonatal abstinence syndrome, which is basically the manifestation of hyperactivity of the central and autonomic nervous systems of the infant. Our nurses, our physicians are well trained at something called Finnegan scoring, which is a system that's been established to evaluate infants for signs of withdrawal. And so any woman with a positive tox screen in pregnancy essentially will have their baby undergo Finnegan scoring for over a course of over at least 5 days to look for withdrawal. Withdrawal in the fetus can actually be significantly delayed. It's not in 4 to 6 hours like it is with the mother. There's limited data on the long-term effects of opioid use in infants. One good thing is there's been no proven long-term cognitive deficiency in infants up to age of 5 in studies that have been performed. So I am going to talk a little bit more about that in a few slides from now, but I can tell you, as far as my approach to the opioid abuse in pregnancy, when patients do have a positive toxicology screen, or when we do identify them with our initial face-to-face interview, we immediately hook them up with certain resources that they will need in order to get into treatment properly, and in order to be a success as far as getting clean and staying clean. So we do get social services involved, obviously, but we also get our mental health professionals involved, our psychiatrists, our addiction specialists, and then our physicians and nurses work in conjunction with those specialists to get our patients the best care possible. One thing about heroin use in pregnancy that we always need to take into account is, like I had stated before, that the baby can acutely withdraw, and that this can be extremely harmful to the baby or potentially result in the death of the infant. For this reason, for our patients who are addicted to opiates, we do encourage them to be on maintenance therapy, meaning we want to give them a medication to treat their withdrawal symptoms, to keep them from acute withdrawal. And the benefits of that are, they reach beyond just for the preventing withdrawal in the baby. It can actually, if you get a patient into treatment with maintenance therapy, it can prevent them from relapsing. It can prevent them from taking part in criminal activities that they use to get the drugs, like prostitution. And it also encourages the patients to get prenatal care as a part of a comprehensive treatment program. So one of the management meds is methadone, and a lot of people have mixed opinions about opioid agonist use in pregnancy, and a lot of people don't understand really that these patients a lot of times can't get off heroin, but even if they could, that it could potentially be harmful for them, and that they're actually doing their baby a service by being on these medications. I know there's a lot of negative judgments towards methadone, but it can actually be very, very useful for getting women into treatment during pregnancy, keeping them in treatment, and actually getting them into a situation where they can parent their children. So one of the benefits of methadone is that it's a long-acting opioid receptor. So it's really great at treating withdrawal symptoms, usually has daily dosing, and the dose is titrated until the patient is asymptomatic. So the goal is not for the patient to be completely high on methadone all day. The goal is for the patient not to have agitation, anxiety, extreme irritability, diarrhea, nausea, and vomiting. The goal is to take care of those symptoms, not necessarily for the patient to just have another method to get high. Subutex is becoming a more and more commonly used opioid agonist during pregnancy. The difference between Subutex and in methadone is that methadone, when it binds to the opioid receptor, has a stronger effect than Subutex. Methadone is like a full opioid agonist, which means that if you do take enough methadone, it can essentially have the same effect as using heroin or other narcotics on the street. Subutex is a partial opioid agonist, and so it's designed to prevent withdrawal symptoms and cravings without allowing patients to have that euphoric effect that some of the other opioids with a higher affinity from the opioid receptor can have, like methadone. So patients tend to not get as much of a high when they take Subutex, or they have to use a lot more in order to get any type of high. So buprenorphine or Subutex has a lot of advantages, in particular over morphine. It's easier to weekly dose this medication, and patients that are compliant in treatment actually can get take-homes where they don't have to come into the treatment center every day. The infants tend to have less severe withdrawal, and there are some studies to show that that these infants use 89% less morphine and for 50% shorter duration. And there are fewer drug interactions with buprenorphine than with methadone. Some of the disadvantages are we don't really have a lot of long-term data on the effects on the fetus because treatment can become less structured. We do have patients that go to the clinic that get Subutex every day, just get their dose every day, just like methadone. But when patients do get to the take-home point, the treatment is less structured. It does obviously increase the risk of abuse or having patients sell it on the streets. And Subutex isn't completely effective for all patients. Some patients really do need methadone to be adequately treated. So it's not necessarily an option for everyone. However, it is a good option for some patients if it can be successfully used in order to decrease the severity of neonatal abstinence syndrome in the baby. So Suboxone is actually a medicine that we avoid doing during pregnancy. Suboxone has buprenorphine in it, which is Subutex, but it also has naloxone in it. So naloxone is an opioid antagonist. So it binds the opioid receptor without activating it and blocks other opioids from binding. So you have the binding opioid stimulator in buprenorphine, but then you also have this blocker, which can block other types of opioids. So if you have a patient on Subutex and you give them Dilaudid after a C-section, if you have a patient on Suboxone and you give them Dilaudid after a C-section, they're definitely going to have almost a complete blockage of that effect due to the Suboxone alone. Subutex can cause narcotics to have less of an effect too, just because it does bind the opioid receptor and is less of an opioid agonist. And so for that reason, it can be difficult treating pain in patients with that medication too, but it's much more severe in patients using Suboxone. So the main reason why we avoid Suboxone in pregnant patients is because if they try to eject it, it causes acute withdrawal, which we know can lead to the death of the infant. So in general, it is discouraged in pregnancy. These are just some illustrations on how these different medications work. So this is just like if you look in the upper left-hand corner at that picture, that is an opioid agonist with the maximum effect. So heroin, morphine, or methadone. In the next slide, just to the right, you can see buprenorphine coming into the picture, and then you see it binding to the receptor, limiting the effect of other opioids there, but still not giving the full effect, so limited opioid effect. This next slide kind of shows, you can do a comparison between morphine, which methadone would be similar, or buprenorphine or naloxone. So in that first one, you can see full activation of the opioid receptor, and then partial activation with buprenorphine, and then with the antagonist naloxone coming into the picture, like with Suboxone, you see that you have an opioid agonist that can prevent or even reverse activation at the receptor site, in addition to having the agonist component. So general management pearls would include good communication between the obstetrician and the addiction treatment program. And in our institution, we actually, the patients in treatment have to prove that they're getting regular prenatal care, and we do correspond well between the treatment center and with the office. I think it's really important, if you don't actually have a physician treating opioid withdrawal and pregnancy in your office, that you do maintain really close communication with your treatment center. Oftentimes the treatment center will be the first to know if the patient's being non-compliant, or if they think the patient's in trouble, or if the patient has a tox screen there that has other substances. And in those situations, we can intervene as the pregnancy becomes more higher risk. It's important to know and recognize the withdrawal symptoms. Treatment can be initiated as an outpatient or an inpatient. When we identify patients with our face-to-face interview that are having an addiction issue, oftentimes what we'll do is a treatment center referral. We'll have them seen there either the same day or within days, and they initiate treatment after the evaluation by a psychiatrist. But I do sometimes initiate inpatient treatment on patients who come into the hospital acutely withdrawing. What you should know is it's illegal for a physician to write a prescription for any other opioid, including methadone, outside of a licensed treatment program. So you can't just prescribe a patient Subutex and they're treated. It has to be included in a licensed treatment program, with the exception of buprenorphine, I think, in the case of treating acute withdrawal. But for methadone in particular, and for Suboxone, they absolutely have to be prescribed within a licensed treatment program. So it's also important to educate these patients well on the potential effects. So patients get in treatment, they're feeling better, they're getting their prenatal care, they're doing what they need to do, they're getting ready for their baby. Some of them even go back to work, but they need to be well educated on the potential effects of the fetus. Babies of mothers who use methadone or other opioid agonists during pregnancy for treatment still can have babies with neonatal abstinence syndrome, even though they're being completely compliant with their treatment program. So I always counsel my patients, your baby's going to be in the hospital for at least 5 days. Your baby's going to receive urine or meconium testing or umbilical cord testing following birth. That Finnegan scoring will be used on the baby, just so that they know what to expect. And so it'll reduce a lot of anxiety for the patient when they come into hospital to give birth, if they know what's going to happen with their baby. So there are some studies that have showed successful medically supervised withdrawal in patients, and it can work, it can be safe for the patient, and it can also be safe for the fetus. However, there's high relapse rates, and for that reason, and when you relapse and have acute withdrawal, obviously that's a threat to the pregnancy in addition to the patient. So due to the high rates of relapse, we generally encourage our patients to get into treatment with an opioid agonist. It can be considered in patients who refuse that therapy, or if the therapy is unavailable. If it is going to be done, it's preferably done in the second trimester. So in patients abusing heroin, which is the most common, or other opioids, for those patients intrapartum and postpartum, we treat them basically the same as we would treat any patient. We're always trying to treat their pain, although it can be difficult because they will not get as great of an effect from giving them any type of narcotic meds as they would if they had not been on those medications. However, we do try to treat their pain. If a person has a C-section, we don't just give them the regular methadone dose and expect them to be in pain. We do aggressively try to treat their pain as well as we can. Epidural is preferred for labor and delivery because an epidural will work on everyone. So we do encourage patients to get an epidural for pain management in labor. And epidurals can also be used in the postpartum period after cesarean deliveries as well, in order to give a long-acting pain control for these patients. It's important always to notify your pediatric staff, because these infants can sometimes have immediate issues after birth, like not being as easily aroused, not making them transition to breathing or to breathing on their own, or being vigorous at time of birth, especially in women that are acutely intoxicated. So it's really important to notify pediatric pediatric staff, and that includes all the nurses that are trained in neonatal resuscitation. The other important part is informing the staff so that testing can be done after birth in a timely fashion for the infant. And like I said before, you can't anticipate that these patients that do need narcotic pain medication, mainly just the patients that had cesarean deliveries or had significant laceration of the perineum, will need more aggressive treatment to achieve good pain control. So as far as NAS goes, these very unfortunate children are usually develop significant distress depending on the amount of opioids the mother was on. Every pregnancy is different, and I have been surprised thinking that, man, this baby's going to have awful withdrawal, and then the baby's withdrawal wasn't as severe. So every patient's different, but in general, you can assume the higher dose of opioid agonist the patient is on, the worse the withdrawal will be for the fetus. And I've listed some symptoms here: tremors, seizures and convulsions can happen, and it's not uncommon for babies in severe withdrawal to develop seizures. Babies tend to have very overactive reflexes. They tend to be very jumpy. So babies naturally have reflexes that they display that resolve as they get older. But these babies have an extremely overreactive reflexes. They tend to have stuffy nose. They sneeze a lot. They tend to be a lot more fussy. It's a lot harder to soothe these babies. They have a higher pitch cry. Oftentimes they will have poor feeding, poor sucking, and weight gain issues. They're born with a higher respiratory rate, and then they maintain a higher respiratory rate. Fever, sweating, skin blotchiness, yawning, difficulty with sleeping, and diarrhea and vomiting are all other common symptoms of neonatal withdrawal. And these are the symptoms that are actually monitored with Finnegan scoring. These substances that can actually cause neonatal abstinence syndrome include opiates, benzodiazepines, like patients using Xanax during pregnancy or Ativan. Some of the barbiturates, alcohol, and methamphetamines have all been associated with neonatal abstinence syndrome. And the Finnegan scoring, as I had mentioned, basically assesses 21 common symptoms in infants. And the score that the infant gets indicates the severity of withdrawal, which guides us in initiating medications for the baby. Next, I'm going to talk to you about alcohol use and maternal health. In our practice, we don't see alcohol abuse as commonly as we do heroin. However, 48% of women of childbearing age do drink, 49.8%, and alcohol use is directly associated with the leading causes of preventable death. So heart disease, overdoses, accidents, and cirrhosis. So there's a large population of women of childbearing age who use alcohol. And in women who do abuse alcohol, they can develop some health conditions that can significantly affect their pregnancy. Heart disease in pregnancy is very severe. Cirrhosis of the liver, abnormal liver function can significantly affect pregnancy. So these are all issues that we have to take into consideration. Alcohol use can also be associated with different types of cancer, as well as multiple vitamin deficiencies. It increases the patient's risk for breast cancer. And like I mentioned, heart disease, alcoholic cardiomyopathy can result in death in patients that become pregnant with that condition. So just any person taking care of women, not just pregnant women, but any person taking care of women should be aware of all of this and should know well how to educate their patients on the effects of alcohol use, not just in pregnancy, but in general. So alcohol use in pregnancy is the most common teratogen, the most common cause of birth defects, leading cause of mental retardation, developmental delay in birth defects. The risk to the fetus is greatest in patients that abuse alcohol during the first trimester, which is unfortunate because a lot of times those patients don't even know they're pregnant while they're abusing alcohol. So fetal alcohol syndrome is the syndrome that can result from alcohol use in pregnancy that I'm going to talk about. And some patients will say, you know, I have a glass of wine here and there during pregnancy, and that's okay. Well, what I tell my patients is that there's no established safe level in pregnancy, none. So I can't guarantee you that if you're having a couple drinks once in a while that it won't negatively affect your baby. And in general, I discourage use completely during pregnancy. So fetal alcohol syndrome is typically associated with three things: growth restriction, prenatally, so detected on ultrasound and also after babies are born or both. It's associated with some specific facial abnormalities, which include epicampal folds, which are extra skin folds over the corners of the eyes, some ear abnormalities, a smooth philtrum, thin upper lip, an upturned nose, and a flat mid-face. And it can also lead to some central nervous system disorders, behavioral disorders, attention deficit disorder, small head size, or mental retardation. So here's some pictures of some really cute children that are unfortunately affected by fetal alcohol syndrome. As you can see, almost all of these pictures have epicampal folds. They have a thin upper lip, absent philtrum, and then you can see ear abnormality in the picture in the bottom right-hand corner there. So for patients who present in labor acutely intoxicated, there's a risk of aspiration or of stomach contents going into the lungs, which can be fatal. That needs to be recognized. There's a risk of acute withdrawal, which can be associated with severely elevated blood pressures, mental status changes, seizures, and in heart failure. These patients also are usually significantly malnourished. That can, and their liver disease can lead to a coagulopathy or blood clotting disorder, which obviously will affect pregnancy. They can also develop a neuropathy, and so anesthesia should always be informed when they're dealing with a patient who has been abusing alcohol in the long term. So the infant may have some immediate withdrawal symptoms like jitteriness, poor feeding, or irritability. Typically, it's likely to occur within the first 12 hours after birth. Fetal alcohol syndrome in infants is treated with barbiturates, and we discourage breastfeeding in women who are abusing alcohol. Women who are, and if in women who do drink alcohol, we tell them to limit it to the equivalent of an 8-ounce glass of wine or 2 beers, and to wait at least 2 hours until breastfeeding again. So cocaine is another substance that can have a very negative effect on the mother and on the baby. And so I was kind of saying before, it's not uncommon for us to have women come back with toxicology screens positive for multiple substances. And so cocaine is something that we definitely see. I generally don't see it by itself. Usually it's with marijuana or some of the effects that it can have on maternal health include seizures, very poor nutrition. Sometimes patients can actually present in complete psychosis. It's associated with heart disease and cerebrovascular accidents like stroke. Cocaine can affect pregnancy in multiple ways, including placental abruption or premature detachment of the placenta. It's been associated with preterm birth and low birth weight, and can also be associated with microcephaly, the birth defect of a small head, a small developed brain, and other cognitive and motor disorders. So for patients who are abusing cocaine during pregnancy, in general, we take into account the potential maternal complications, which can include a blood clotting deficiency, blood pressure issues, heart problems. These patients will have significant pain control issues. However, there's really no acute neonatal abstinence syndrome, and we do obviously discourage breastfeeding if patients are actively abusing. Methamphetamines are also part of what we sometimes see in women using multiple substances during pregnancy. And a lot of times patients will say, actually, well, they'll admit to using heroin, but they'll say, I never used methamphetamines. Well, a lot of times now marijuana and heroin are being laced with methamphetamines to perpetuate the addictive effects and to increase the amount of money in the drug dealer's pocket. And so I do believe patients when they come in and say, I've been using heroin, I never used meth, because they probably could have potentially done it unknowingly. It's most frequently used after alcohol and marijuana. It's been associated with heart arrhythmias, high blood pressure. It's been associated with seizures. There's an increased risk of high-risk sexual activity, which increases the risk of diseases that can affect pregnancy pregnancy, and that includes sexually transmitted diseases like chlamydia. The patients who are using methamphetamines oftentimes suffer from insomnia, anxiety. They can be very confused or have memory issues. And there are psychotic features too. So if you have a patient presenting in psychosis, a toxicology screen is an important part of that evaluation. These patients also can have extreme dental issues, which for pregnancy can lead to bad pregnancy outcomes. Bad uncontrolled periodontal disease in pregnancies actually can be associated with preterm birth and other bad pregnancy outcomes. So as far as the effects on the fetus go, it can cause central nervous system defects, heart defects. It has been associated with some birth defects like an oral cleft or limb defects. It can cause gastrointestinal issues in the baby, and in the long term, it can cause attention and memory issues or even visual motor integration issues in the baby. However, there are no case control or prospective studies on these effects, and so the data is somewhat limited. For patients abusing methamphetamines, we always consider the maternal complications. We completely anticipate problems with the infant, which can include decreased arousal, increased stress, and poor quality of movement following birth. In breast milk, it's 2.8 to 7.5 times higher than in maternal plasma. So the levels going to the baby are actually higher than in the mom. It's more concentrated in breast milk. So obviously we encourage these patients not to breastfeed. So those are all the substances that I'm going to talk to you about in pregnancy. They're the most commonly abused substances. Now I'm going to talk to you about just the management pearls and how we need to approach these patients. So in patients being treated with medications, we need to keep in mind that there's no easy fix of medication in pregnancy that you can use. It's always a multifaceted approach that will allow patients to be successful and to have healthier babies. And that includes prenatal care, chemical dependency counseling, family and group therapy, and also psychosocial services. And families are very important in being involved in addiction. And I can tell you patients that have family support, particularly pregnant patients, are much, much more likely to be successful than patients who have no support at all. Our patients are required to participate in group therapy, and we also have pregnancy group, which incorporates things like life skills, parenting skills for our patients, and we also encourage them to attend our birthing classes and breastfeeding classes if they are in a position where they can breastfeed. We do encourage patients that are on our opioid agonist medications to breastfeed because it can help reduce withdrawal in the infant. These are also some management pearls for our patients who are in treatment. It's important, like I stated initially, not to judge these patients. Educate them. Let them know these are the effects this drug or this medication can have on your body. These are the effects that it can have on your baby. Respect them enough to allow them to be well informed of what they're doing to their body. A lot of them don't even know. They need to be monitored like any high-risk patient. And as you could see by these past several slides, there are a lot of increased risk to pregnancy in these patients. They need more frequent visits. Sometimes they need more frequent ultrasounds and lab testing, particularly in monitoring patients with HIV. Oftentimes they're monitored in conjunction with an infectious disease specialist. Patients with hepatitis, that we also include our gastroenterologists in their therapy, and they require more structured lab testing throughout the pregnancy. And so like these patients, because of the increased risk to mom and fetus, require a lot more monitoring for their high-risk pregnancies. And patients who are successfully in treatment and who are being compliant, we encourage them to be parents. We encourage them to take care of their babies. And I tell patients this during the pregnancy because a lot of them come in with a lot of fear. You know, if I tell you that I have a problem with heroin, you're going to take my baby away. And what I do is I tell my patients, if you get into treatment, you are successful and compliant. You will be investigated by DCS, and that will become a big part of your parenting your child. However, separation between you and your baby will be minimized, and you will have a chance to parent your child. Some of the biggest barriers to identifying patients who abuse substances and to treating them are poverty, which can be associated with lack of education. So a lot of patients don't know what treatments there are available for them. They don't know the effects that their substance abuses have on the pregnancy. A lot of patients can't afford treatment. Now, there are some treatment centers that accept Medicaid, including pregnancy Medicaid, and some that require out-of-pocket costs. We're fortunate enough at our treatment center to have a program that works with pregnant patients who can't pay, so that no pregnant patient that's willing to be compliant with the program has to withdraw during pregnancy. Transportation can also be an issue. However, if patients can qualify for pregnancy Medicaid, they can get rides to their doctor visits. So there are opportunities available. But if the patient doesn't come in and talk to you, you can't tell them about this. A lot of people have fear, and this is why they avoid prenatal care. They have fear you're going to find out that they're using, that their baby's going to get taken away, or that they're going to end up in jail. And the goal is never to incarcerate a patient or take their baby away. The goal is always to get the patient healthy so that they can parent their babies, and I emphasize this to my patients. And then a lot of times these patients are obviously very sick, and for that reason are unable to get into the doctor. So what we do to try to overcome barriers is the face-to-face interview with identifying these patients. And I can tell you now, since our program for mothers and for babies who use illicit substances during pregnancy is now well established, and we have a reputation in the community for being caring toward mothers who are struggling with addiction and toward encouraging them and helping them, that patients will come in and be honest. Like patients, we have a high-risk pregnancy navigator, and patients will come in and bare their souls during that face-to-face interview. And you would think that they wouldn't, but if you can build a reputation of compassion and foster a relationship based on mutual respect and trust with your patient, they will be honest. So I'm a big believer in the face-to-face interview with these patients who do choose to come in and get prenatal care. And then, as I stated before, we do a drug screen on everybody with their initial prenatal visit, and then also in the hospital. So as far as management goes, as I stated before, patient education on treatment options available and the effects for their health and the baby is important. Treatment referrals are always initiated immediately in patients who are abusing substances during pregnancy. And of course, there's medications, and particularly in patients with heroin addiction, the opioid agonists. Close correspondence between the obstetrician and the treatment center is 100% essential. It's 100% necessary, because you can't get a patient successfully treated and a patient to have a healthy baby without the OB care, and also without the addiction treatment care. One without the other will not result in a successful delivery and healthy baby. And so it's really important for all of the players, the therapists, the psychiatrists, DCS, and the obstetrician to remain in close correspondence with each other. And then, as I stated before, close follow-up surveillance in the office and follow-up with DCS. And then our patients early on are introduced to all the support that's available to them as far as our education, as far as some of the resources in the community to help people with financial difficulties in transportation. And then lastly, and most importantly, encouraging these patients and having compassion on them, recognizing that there are people with a medical illness that need a loving, caring provider to have faith in them and to have hope for them. A lot of these patients grew up in abusive situations. Almost all of them have underlying mental illnesses. A lot of them come from families that have continuously perpetuated a cycle of addiction, and they've never really had anyone believe in them or encourage them. And having a provider do that can have a really big effect on these patients. So part of our prevention plan is we started a free birth control clinic for patients in our community. It's still kind of just getting started, but it's important to make easy access to contraception for patients dealing with addiction. Because like I stated before, I've never had a single patient tell me that they planned to get pregnant while they were addicted to heroin. Never had a single one. So if I make contraception readily available to that patient that's struggling from addiction, maybe we can get her properly treated before she has a baby and prevent neonatal abstinence. As far as postpartum treatment goes, some of these patients undergo supervised withdrawal and transition to other long-acting medications like Vivitrol or just outpatient therapy. Some people continue on Subutex and methadone, but we do encourage these patients to continue treatment in the postpartum period and to continue working on their overall wellness so that they can parent their child. And then we also offer a lot of support for these patients postpartum. I always see patients early in the office. They are not only are they at high risk for a relapse just because of the stress of being a new mother, which anyone who's had a child knows what that's like, the sleep deprivation. It can be a really high pressure, high stress time. So I always see these patients back early. All our patients, every patient gets a follow-up phone call from a staff member. And then patients can also be transitioned into inpatient facilities. And there are some facilities that will accept mother and baby together. We take a hospital approach, a hospital-wide approach in preventing substance abuse by convening together in hospital-wide and unit-based discussion groups with multidisciplinary teams in order to help us best approach the addiction problem, not just in our patients, but in our community. And community outreach is very important. There are a lot of local community organizations who are concerned about substance abuse, and particularly in pregnancy. And I think it's important for our providers to have knowledge of these things, to go out into the community and to speak to people about what we're doing to help the problem and to get their feedback and input on what we can do to better serve them. And that is my talk for today. Thank you so much for listening to me.